Good morning and welcome to our Alaska Collaborative on Health and the Environment teleconference on the Ecology of Breast Cancer, Opportunities for Prevention with Dr. Ted Schettler. My name is Diana DeFazio, and on behalf of Alaska Community Action on Toxics, I'll be facilitating today's call. CHE Alaska is a regional partnership group of the National Collaborative on Health and the Environment. CHE Alaska aims to advance knowledge and effective action to address growing concerns about the links between human health and environmental factors. You can find more information at akaction.org and healthandenvironment.org. Again, I sent a link to the presentation slides yesterday to everyone who signed up for the call, and for those of you who signed up this morning, you should have also received them. Please take a moment to download Dr. Schettler's presentation so you can follow along. And Dr. Ted Schettler is currently in Alaska on a lecture tour presented by Alaska Community Action on Toxics and the Alaska Run for Women. And he's been meeting with healthcare professionals and speaking at community events in Anchorage and Fairbanks. Tomorrow he travels to Nome, where he'll be speaking at Old St. Joe's Church. There will be a reception at 6:30 p.m. and the program begins at 7 p.m. And if you have any questions about that event, you can call the ACAT Anchorage office at 907-222-7714. Now it's my pleasure to welcome and introduce Dr. Schettler. Ted Schettler is Science Director of the Science and Environmental Health Network, a non-governmental organization that engages communities and governments in the effective application of science to protect and restore public and ecosystem health. He also serves as Science Director of the National Collaborative on Health and the Environment and Science Advisor to the Health Care Without Harm campaign. Dr. Schettler has a medical degree from Case Western Reserve University and a master's in public health from Harvard. Schettler is author of The Ecology of Breast Cancer, The Promise of Prevention and the Hope for Healing. And he is co-author of Generations at Risk, Reproductive Health and the Environment, In Harm's Way, Toxic Threats to Child Development, and Environmental Threats to Healthy Aging. He has published a number of articles on related topics in peer-reviewed journals and has served on advisory committees of the U.S. Environmental Protection Agency and the National Academy of Sciences. Welcome, Ted. You may go ahead and begin.
Thank you very much, Diana. Good morning, everyone. Can you hear me okay, Diana?
Yes, you are effectively unmuted.
Wonderful, thanks.
Coming through clear.
Good morning, and thank you very much for joining us. You will have the slides I'm going to talk from in front of you, so let's go right into slide number 2, where there's an image of the cover of the book, and I just want to make you aware that if you're interested in getting a copy of the book, you can download a free PDF from the Science and Environmental Health Network website, which is shown on the slide, or if you're interested in purchasing a hard copy, you can find one through Amazon simply by Googling the title of the book. Move to slide 3. This is an outline of what I'd like to cover in the next few minutes in this conversation. I want to pose an ecologic framework as being useful for thinking about the origins of breast cancer. And then after having done that, to look within the complexity at some of the risk factors that we know about and that we're becoming more aware of as we think about what we might do to intervene to prevent breast cancer, and then finally putting it back together again and thinking about how we might design for preventing breast cancer. On slide 4, I would just take a minute to talk about what I mean by the ecologic framework and why I chose to look at it in this way. After looking at breast cancer risk factors and patterns of breast cancer for a long time, it seems to me that it's clear that we cannot attribute breast cancer patterns to one or two risk factors that explain what we're seeing. Nothing comparable, for example, to cigarette smoking and the impact it has on lung cancer risk. But rather, it's a complex mixture of risk factors that collectively create the conditions out of which breast cancer patterns arise. And so it seems to me it's useful to think about breast cancer as a systems problem requiring a systems-like response. It's multidimensional, multifactorial, interactions and relationships are important, and history and time are important. If we look at migration studies, they're very instructive. If women move from a country of low breast cancer incidence to a country of high breast cancer incidence, after 1 or 2 generations, they acquire the higher breast cancer risk of the country they move to. If a child moves from a country of low breast cancer incidence to a country of higher breast cancer incidence, she acquires that higher risk even more rapidly. And this tells us that early life events seem to matter in terms of shaping breast cancer risk. So I think that we can put these observations together and think that an ecologic framework is useful, one that looks at a multidimensional, multifactorial interrelationship among many factors over time that shape the terrain, that alter system conditions resulting in breast cancer patterns. So on slide 5, this can be depicted as the individual sequentially nested within families, communities, ecosystems, and societies, where there's a lot of crosstalk from one level to another here. And on slide 6, we also see that there are biologic implications and impacts of each of those levels at various levels, even within the individual, at the tissue level, at the cellular level, and even subcellular level. So this is sometimes people talk about this as the environment getting under the skin. On slide 7, here we see the importance of looking at the life course where various exposures during fetal development, infancy, and childhood collectively influence childhood health or illness, but that in turn influences adult health or illness. And this is a theme that I think has emerged for a number of diseases and disorders over the last 20, 25 years that are that we should really keep in mind. If you look at slide number 8, I've shown this in a graphic here where things like an unhealthy diet, physical activity, a lack of physical activity, toxic exposures, and social stressors during pregnancy, for example, and fetal development and infancy and childhood can lay the foundation for health or disease in midlife and even beyond. Things like hypertension, cardiovascular disease, diabetes, and various kinds of cancer may have their origins very early in life. And we now know that even some of the degenerative diseases very late in life may have their origins much, much earlier. And I'm going to be talking a little bit later about some of the evidence that early life exposures to, for example, diethylstilbestrol and DDT actually can increase breast cancer risk much later. So on slide 9, I just want to quickly make the observation that when we look at breast cancer patterns and incidence rates in Alaska, we often see a chart that looks like something like this. These numbers are a little bit dated, but the point that I want to make here is that if you look at the row where I've got a red arrow pointing, Alaskan Natives and American Indians are often lumped together, and you would look at that second column there and you'd say, well, their incidence rate of breast cancer is really quite a bit lower than non-Hispanic white women who are at the top there. But in fact, if you look at the bottom, text at the very bottom of the slide, you'll see that when scientists actually disaggregate these data, that Alaskan Native women have an incidence rate of breast cancer that's every bit as high and maybe even higher than non-Hispanic white women generally throughout the United States. So that it's a real problem for Alaskan Native women and women in Alaska more generally as we think about what we might do to intervene and help prevent some of this. So on slide number 10, how do we frame this question of breast cancer prevention? Do we think about it just at the individual level, or do we think about it at the population level? And as a public health matter, I choose to look at it as at the population level, recognizing the importance of the individual level as well. When particular women are seeing a healthcare professional and are concerned about a particular risk of breast cancer because of a family history or something of that kind, that decisions in that context are very important to make. But we also want to keep in mind that looking for strategies that will dampen down risk across the entire population so that we will see generally fewer cases if possible. And I would re-emphasize that overall evidence points strongly to accumulation of risk throughout the life course, beginning during fetal development. On slide 11, I'm showing well-established risk factors here, and you can read these. I don't need to go through them one by one, but these are some of the risk factors that I think are generally well accepted by most people as being involved in the origins of breast cancer. And the ones that I've got in a red font on these slides are ones that are potentially modifiable during childhood. And I want to emphasize that again because we're increasingly aware that this life course approach matters and that early life events matter in terms of establishing breast cancer risk. So here is where we, in these ones that are denoted in red, these are opportunities that we can begin to look at for early life interventions that may begin to reduce risk as it accumulates over time. At the bottom of the right column, I've added in diet and reduced exercise and physical activity. I think probably a few years ago, those wouldn't have been included in a list of well-established risk factors. But I think the data are pretty clear that they do belong there, and I'll show you some information to justify putting them there. Now, if we look at this list of risk factors and think about their interactions and try to model this in some sort of a graphic that would help us understand the dynamics of this complex system, it can get pretty messy. Dr. Bob Hyatt and his colleagues at the University of California, San Francisco, actually attempted to do that. And if you look at slide 12, you'll see what they came up with. And this is a model of postmenopausal breast cancer incidence. And usually when people take a look at this, there's sort of a smile and sometimes a gasp, and then there's a sort of inclination to throw up your hands and say, what am I supposed to do with this? And I understand that. It's the usual sort of spaghetti plot that happens when you try to look at dynamic interacting systems. But we can tease this apart a little bit. So look in the upper left corner, they have the socio-cultural domain. In the lower left, the behavioral domain. In the upper right, the physical-chemical domain. And then in the lower right, the biologic factors. And you will also notice that some of these lines are thicker than others. Some are dotted, some are dashed. In the lower left, you'll see the key that helps you understand what those mean. So they've been able to parse this out, showing, for example, with the width of the arrows and the lines, where the associations are the strongest. Which of these factors have the biggest association with breast cancer risk? And then in the key right to the right of that, you'll see that they're also parsing it out in terms of the quality of the data. Where's the evidence the best? And so what you can do with this model, if you go to that link at the bottom of the slide later on and want to play with this a bit, you can actually, this is an interactive model that you can build from the bottom up, or you can just look at portions of it one at a time and begin to understand these in a little bit more detail. But having said all of that, we still have quite a complex model here that we might find it difficult to interact with or to learn from. And so if we go to slide 13, I think it's completely reasonable to ask, why should we even do this? I think it's useful for a number of reasons. First of all, it helps us to acknowledge and communicate complexity. This is really a systemic problem, which is what I began with when I began talking about breast cancer as a systems problem requiring a systems-like set of responses. It highlights the need for broad and diversified efforts to study and change the dynamics of the system. And I think rather than us focusing on a single risk factor, we begin to think about the dynamics of the entire system. How do we shift the operations of that system in ways that make the emergence of breast cancer less likely. It also helps us to make sense of the complexity. We can begin to understand the general architecture, and then once we do that, we can begin to identify more granular variables and details that we might want to try to modify. And on slide 14, it helps us, I think, to support the development of strategies to both do research and study the origins of breast cancer, as well as designing interventions that will help us to change the dynamics of the system. We look for leverage points in this complexity, for feedback loops that we might want to influence, and causal cascades, where if we strategically pick an intervention point, we might have dramatically enhanced downstream effects if we do that strategically. Having said all that, one will never understand this complexity in fine granular detail. There will always be a certain amount of uncertainty, and I think that we should not allow that residual uncertainty to be an excuse for not taking action. Rather, we should think about how we can act based on the information we have at any given time. So on slide 15, I want to start getting into some of the general topics that are included in this model. I'll start with diet in breast cancer, and I'll say that just as a general introduction, that dietary studies of breast cancer risk go back more than 30 or 40 years. I think it's fair to say that a lot of the earlier studies were limited in a variety of ways. Most of them focused primarily on single or individual micro or macronutrients. The whole concept of dietary pattern analysis is relatively recent, and I think has been generally more productive than looking at single dietary ingredients. Most of the epidemiologic studies, initially at least, included large preponderance of white women and not other ethnic groups. Most studies failed to address exercise or other variables as not only a confounder but an effect modifier of diet and its influence on breast cancer risk. And I think this is a real shortcoming. And then no studies in people have examined whether diet modifies the response to an environmental chemical, for example, although there are animal studies that say we really ought to be looking at that. For example, maternal diet during pregnancy may influence the susceptibility of her daughter to breast cancer after exposure to an environmental chemical sometime during or after puberty. So these are some of the limits of the dietary studies. Slide 16 summarizes, I think, what we've learned about dietary fat and breast cancer. These summary statements come from an analysis of a fairly large number of studies, and I'll point out that the references for all of this that's in this presentation are in the book. So those of you who want to go to the original research can find the references in the book. Higher amounts of saturated fat and certainly trans fats probably modestly increase the risk of breast cancer. Strikingly higher ratio of omega-6 fatty acids to omega-3 fatty acids also probably increase the risk of breast cancer. Omega-6s and omega-3s are both essential fatty acids, or polyunsaturated fatty acids, but our current diet that's so dominant in the Western world has a large preponderance of omega-6s over omega-3s for reasons that get into the way the food industry has undertaken processing of food for long shelf life and so on. High dietary omega-6s in pregnancy probably also increase the risk in offspring through changes in hormone levels, and I've given a couple of examples there. And I think it would be right to say that substitution of some of these saturated fat and high levels of omega-6s, substitution with omega-3s and or olive oil is highly likely to be beneficial and reduce risk. On slide 17, if we look at adult diets and breast cancer risk, higher intake of fruits and vegetables is clearly beneficial, and we see a significant decreased risk with diets that are loaded with fruits and vegetables. And you'll notice in the lower right some of the more beneficial vegetables, these are the ones that are deeply colored. The reds and purples and yellows and greens and so on that have high levels of carotenoids. These are phytochemicals in those foods that have many beneficial effects. And interestingly enough, higher soy consumption, and when I talk about soy here, I want to emphasize that I'm talking about whole soy products, only lightly processed, things like tofu and miso and tempeh, and I'm not talking about fractionated soy and soy supplements. It's a big difference, and they have very different biologic effects. But higher whole soy consumption really seems to be associated with decreased risk of breast cancer. The effect size of this is larger in Asians than in Westerns, and there are probably several reasons for that. One being that the typical Asian diet or the traditional Asian diet frequently has much more whole soy products in it than the Western diet. And there are also some microbiome differences after many years of eating a high soy diet that may also influence the metabolism of soy and its beneficial effects. One long-term study in Europe has actually found that even in women with breast cancer, that if their at the time of diagnosis, if they had higher baseline levels of these healthful carotenoids in their blood, that their prognosis after initial treatment was improved. On slide 18, we can say, I think, that the Mediterranean dietary pattern really does decrease risk. You'll see a depiction of that in the lower right, a diet that's rich in fruits and vegetables, whole grains and not refined grains, seafood, nuts, leafy greens, and healthy fats. Olive oil is featured in the Mediterranean diet. A recent study that has come out of Europe called the PREDIMED study is a prospective study of postmenopausal women showing that a Mediterranean diet that was supplemented with just 2 tablespoons of extra virgin olive oil daily was associated with a 68% decreased risk of breast cancer compared to people who were on a controlled diet just over a 5-year period of follow-up. So that corroborates some of the previous studies that have ended up recommending a Mediterranean-like diet. And I think it's probably true, it's probably fair to say that the westernized dietary pattern, which might look like something on the lower left, is generally associated with an increased risk of breast cancer. But one of the more interesting things, if you go to slide 19, that's emerged in recent years is that childhood and adolescent diet seems to matter a lot. The beneficial impacts of more whole soy in the diet seems to be even greater when that is a feature of childhood and adolescent diets. And you'll see here a general statement on the first bullet about decreased breast cancer risk of about 50% in women whose childhood and adolescent diets featured more whole soy. And this summary number comes from 3 or 4 studies that have really tried very hard to look at adolescent and childhood diets and see what influence they had on breast cancer risk. The Nurses' Health Study 2, which has been going on for a number of years, and we're beginning to see a number of papers that are coming out reporting results of that, have in the last couple of years reported that girls and adolescents who have particularly high levels of red meat in their diet are at increased risk of both pre- and postmenopausal breast cancer. And from Nurses' Health Study 2, they concluded that if an adolescent were to substitute just 1 serving per day of meat with legumes, you could see these kinds of risk reduction that are noted in the lower bullet on this slide. And on slide 20, we also see from not only Nurses' Health Study 2, but also from an ongoing study called Growing Up Today, which you'll see there in the first bullet, that benign breast disease, which itself is a risk factor for breast cancer, can be related related and is associated with diet, that higher levels of vegetable proteins, healthy fats, and nuts result in, or at least are associated with, a reduced risk of benign breast disease. Girls who drink lots of milk not only have an increased risk of benign breast disease, but they have more rapid height growth during their growth spurt, and that itself is a risk factor for breast cancer. Now, that's not to say that girls shouldn't drink some milk, but this is, in this study, the girls who drank the most were drinking really lots of milk. So there's probably a minimum amount that girls ought to drink and a maximum amount that they shouldn't drink, and finding the sweet spot is what we're looking for. But it's interesting that to see this association with benign breast disease and rapid height growth. And then finally, there's increasing evidence that both increased childhood dietary meat throughout childhood, and this is primarily red meat here that I'm talking about, as well as sugar-sweetened beverages, both advance the age of puberty. Again, a risk factor for breast cancer. And on slide 21, you'll see the relationship of dietary fiber in adolescence and breast cancer risk. And if you just look in the center of that graphic on this slide, this is premenopausal women with breast cancer and their dietary fiber during adolescence. And you'll see a pretty strong relationship here, that the women whose dietary fiber was highest during adolescence had a strongly reduced risk of breast cancer later in life. Moving on to exercise and physical activity on slide 22, there are more than 30 or 40 studies that have looked at this relationship, and it's pretty clear that more exercise, regular exercise, is associated with a decreased risk of breast cancer. Approximately 3 to 4 hours a week of moderate exercise, which is equivalent to what we might call brisk walking, really will confer a decreased risk of breast cancer, and this is both for pre- and postmenopausal women. Adolescent exercise is most strongly associated with a decreased risk of premenopausal breast cancer. That is not to say that it's too late to start exercising after adolescence. That's not the case. There are benefits throughout life, but I think the message that I take from this is that it's important to start early, continue through adolescence, and continue through adulthood. A number of mechanisms are involved. They've been well studied. We probably know a lot about many of them. It's not just weight control that's involved with exercise, but it literally helps alter hormone and growth factor levels and modifies gene expression in very beneficial ways. So we understand some of the ways in which exercise can reduce breast cancer risk. And I would add that exercise after diagnosis and treatment also improves quality of life, and many studies show a reduced risk of both all-cause or breast cancer-specific mortality. And so exercise should be a component of a more integrated approach to breast cancer care after initial diagnosis and treatment. On slide 23, 30 to 60 minutes of moderate exercise 5 days a week is what's recommended for all people, and children and teens should be getting more than that. However, we all know that that's not happening, and it's not, I think, just a matter of individual behavioral choices, but rather the context in which children and adolescents are growing up. We look here at the bottom of this slide. There are some of the determinants of exercise levels that are listed here. Important are, for example, self-efficacy or the confidence in their ability to exercise. There's a certain reluctance in children who think they might not be able to accomplish certain physical activity tasks, so we need to address that. We need to address family and social support, particularly with adolescents. And I would add that we need to think about how do we weave this back into the fabric of the school day when it's often the first thing that's removed during budget cuts or stresses on test performance or one thing and another. Children often find themselves in a school where they get no particular physical exercise at all during the day. This is completely a counter to the public health message that we ought to be putting forth about the importance of physical activity and exercise as a daily activity. On slide 24, I want to move on to environmental chemicals. About 75 years ago, a scientist who subsequently was awarded the Nobel Prize for his work actually used a chemical called DMBA, which is a polycyclic aromatic hydrocarbon, to quite reliably induce mammary gland cancer in laboratory rodents so he could study the hormone responsiveness of this cancer. Yet years went past before anybody published a study in which they had looked to see whether or not environmental chemicals could have anything to do with the origins of breast cancer in people. The first one I was able to find was a study of women hairdressers in the UK who, in the 1950s and 60s, and this paper was published in the early 70s, seemed to be have an increased risk of dying from breast cancer. And when someone investigated this, they found that they were regularly handling chemicals in their work as hairdressers that were probably quite clearly carcinogenic. Subsequent studies looked at breast cancer mortality in some women in a PVC plastic manufacturing plant where the risk was increased. Another one found an increased risk in women working in a Swedish factory where they were handling an oil that they were putting onto metal rings to prepare them for shipping. The oil was intended to reduce the risk of rust on these metals, and the oil was carcinogenic, and these women were getting excessive cases of breast cancer and dying of breast cancer. Things went sort of quiet after that in the epidemiologic medical literature, but with this background, there was some enthusiasm about beginning to look at environmental chemicals and their influence on breast cancer in laboratory animal models. And several years ago, Ruth Ann Rudell and colleagues from Silent Spring Institute published a paper in which they did a review and found over 200 chemicals that were industrial chemicals or present in consumer products that are mammary gland carcinogens in animal studies, in at least one or two well-conducted studies. Unfortunately, only a handful of those had been looked at all in terms of their risk to humans. On slide 25, in 2011, the Institute of Medicine convened a panel and they did a limited review of the evidence and concluded that there's strong evidence that hormone replacement therapy, current use of oral contraceptives, alcohol, and tobacco smoke are carcinogenic and increase the risk of breast cancer. Found less strong but suggestive evidence that a number of other solvents, and benzene, ethylene oxide, 1,3-butadiene, and some polycyclic aromatic hydrocarbons are likely to be associated with an increased risk of breast cancer. And then they raised concerns about a number of others where the evidence was suggestive but incomplete or inconsistent, and they specifically named endocrine-disrupting chemicals like bisphenol A, cadmium, and a number of others. Just this year, on slide 26, the Breast Cancer Fund has released a report that they did in which they looked at the medical literature to see which occupations are associated with a higher risk of breast cancer, and you'll see them listed here. Nurses, teachers, professional women, x-ray technicians, firefighters, and women working with chemicals all seem to be at increased risk of between 1.5 and 6-fold. It's a very nice report that you might want to download and take a look at in more detail. And then I want to go on slide 27 back to this life course approach to point out that we actually have human epidemiologic data showing that women who took diethylstilbestrol during pregnancies during the 50s and 60s actually altered the breast cancer risk of their daughters, so that now enough years have passed, and a study was published in 2006 showing that women who were exposed to diethylstilbestrol while fetuses in the womb are at about a 2-fold increased risk of breast cancer after they reach the age of 40. So this really is consistent with the notion that breast cancer risk can begin early all the way back into fetal development. More recently, Barbara Cohen and her group from the Bay Area of California have published a couple of studies showing that higher early life exposure to DDT, the pesticide, is associated with an increased risk of breast cancer. They first showed that higher levels of exposure before the age of 14 was associated with about a 5-fold increased risk of breast cancer, and more recently they've reported that higher levels of DDT exposure in utero are associated with an almost 4-fold increased risk of breast cancer. So I think these two examples tell us that we need to begin thinking about breast cancer prevention in the womb. And on slide 28, I just want to point out that an area of intense interest and research right now has to do with endocrine disruptors and breast cancer risk, where early life exposures during development can influence breast development, literally change the tissue architecture and gene expression in the developing breast after developmental exposures, resulting in an increased susceptibility to breast cancer later. And bisphenol A, which will be familiar to many of you, is one of the chemicals that can do that. And I've also noted at the bottom that atrazine, a highly used herbicide, and these more commonly used neonicotinoid pesticides both promote aromatase production in vitro testing, and in atrazine's case, in vivo testing, which in turn increases the activity and production of estrogen. So these are chemicals that, through a pathway that's fairly well defined here, might also influence breast cancer risk after developmental exposures. Let me go quickly on to vitamin D, slide 29. I particularly bring this up with great interest while here in Alaska because of the low light during the winter months. Many people in Alaska do have inadequate levels of vitamin D at various times of the year. Low vitamin D in animal studies and in vitro studies is clearly associated with an increased risk of mammary gland tumors. Some of the mechanisms have been well worked out. You'll see reduction in aromatase levels with higher levels of vitamin D, and modification of the whole cellular proliferation differentiation pathways in beneficial ways if vitamin D levels are adequate. However, they're not adequate in many people, not only in Alaska, but throughout the country. This is an area where we might actually think about making some interventions to help prevent breast cancer. Most, but not all, studies of vitamin D status in human epidemiologic work have shown lower levels associated with a higher breast cancer risk. And a prospective study done in Colombia found low vitamin D levels were actually predictive of earlier onset of puberty, a risk factor for breast cancer. On slide 30, if we look at what the Endocrine Society and the Institute of Medicine say are adequate levels, they don't entirely agree, but that aside, use whichever one of those numbers you'd like. We can say with confidence that inadequate levels of vitamin D are common in populations in the United States, and in fact the American Academy of Pediatrics already recommends that all breastfed infants should be receiving vitamin D supplementation. That's not regularly happening, but that's a recommendation from that professional society or academy. The American Congress on Obstetrics and Gynecology also recommends testing women who might be at risk for vitamin D insufficiency and supplementing during pregnancy. And you'll note that there's a wide margin of safety here. The Institute of Medicine says that adults can take up to 4,000 international units of vitamin D3 daily quite safely. Unfortunately, on slide 31, you'll see that vitamin D insufficiency is common in Alaska, particularly during the winter months. Alaskan natives who eat a traditional diet are more likely to have adequate vitamin D levels year-round. But as Alaskan natives move away from a traditional diet for one reason or another, they too are at risk for inadequate levels. On slide 32, I briefly want to mention radiation. There's no question that ionizing radiation, such as that from X-rays, is a well-recognized risk factor for breast cancer and for other cancers as well. What's not so well known is whether, or what's not well understood is whether non-ionizing radiation, such as that comes from cell phones and other sources, might increase cancer risk. It's not ionizing. It does not have the power to break DNA bonds, and so many people have thought, well, gee, it's probably not a concern for cancer because of that. However, there are a lot of studies that have been published in recent years showing biologic effects of non-ionizing radiation that may well increase cancer risk. And in fact, the International Agency for Research on Cancer actually classifies radio frequency radiation from cell phones as possibly carcinogenic to humans based on a possible brain tumor risk. We have no studies of this kind of radiation on breast cancer. However, there have been reports that have been in the medical literature, just anecdotal reports of young women who have developed breast cancer in the breast beneath the spot where they carried their cell phones in their bras. And whether or not that's a causal relationship is unclear, but I point this out simply because it's easy to get rid of that exposure by not carrying a cell phone in the on position in a bra. And I think we ought to be recommending that to girls and adolescents. So that's the purpose for bringing this up. So if we go on to slide 34, we might then think about how we're going to sort of integrate all of this into designs for prevention, thinking about the life course approach, thinking not only about medical and behavioral interventions, but how do we do this from a public health perspective? Where are the opportunities for multi-level interventions, for public health thinking, where we actually shift those system dynamics that I mentioned at the beginning, redesign the terrain in ways that make breast cancer less likely, population-wide shifts in risk factors. If we can figure out ways to do that successfully, we have real opportunities for reducing breast cancer incidence across entire populations of people. We understand that it's difficult to establish cause and effect relationships with great certainty. There's always going to be some uncertainty because of the complexity of that system's approach and diagram, but we should not use that as an excuse not to act based on what we do know. And on slide 35, you see that if we combine risk factor reduction, this is a study done in Europe, large number of people, postmenopausal women, you actually see in the bottom bullet there that you see quite a dramatic reduction in breast cancer incidence. In women who combined the highest scores on combinations of healthy lifestyles, which included diet, exercise, weight control, smoking, and alcohol. Well, okay, that's great. For them, these are dietary, behavioral interventions, but how do we apply these observations across entire populations? How do we make healthier diets available more broadly and encourage their distribution, access, and availability? How do we weave exercise back into the fabric of people's daily lives more regularly, and so on? On the next slide, you'll see that the influence of combined interventions even in women who have breast cancer. This is from the Women's Healthy Eating and Living study, where combinations of diet and exercise after initial diagnosis and treatment resulted in quite a significant improvement in survival over 10 years. This is in women who had already been treated for breast cancer. And I would point out in the bottom here that, again, even in women with breast cancer who have been treated, 3 fairly large studies find no evidence of adverse effects of dietary soy on breast cancer prognosis, and considerable evidence of a beneficial role. And again, I want to emphasize that I'm talking about whole soy here and not soy supplements. And I think this is now becoming more generally accepted throughout the oncologic community as well. So don't necessarily shy away from whole soy products as a part of a nutritious diet. Slide 37, who's involved here? Everyone's involved. There's something for everyone here, not only for individuals and their behavioral choices, but healthcare providers and institutions public health professionals, governments, legislators, schools, the workplace, farmers. Who's raising our food? What are the incentives that are leading them in one way or another? How is the food being distributed? What can we do here in terms of agricultural policy to address some of the inadequacies in the food system now? And city planners who can make decisions that will actually foster diet, exercise, and a number of other healthy interventions that can happen as a result of the way we put our towns and cities together. Slide 38. Cancer prevention begins in the womb, begins with diet and nutrition and the food system, food access, emphasis on the things that I have talked about. Breastfeeding is good both for mother and for baby, and we should be encouraging it. Baby benefits in many ways. Mother will realize a number of benefits as well, including modest reduction in breast cancer risk. Exercise and physical activity, I've mentioned. We should be optimizing vitamin D levels across the population and supplementing where necessary to get them up into a range that we know is more beneficial, and avoiding unnecessary radiation exposure. And I think there's a lot of room for improvement here, where young people in particular during periods of windows of vulnerability during development are being exposed to unnecessary radiation. That's not to say that X-rays should be avoided when they're necessary for health care, but we all know that often X-rays are being done for reasons that are really not necessary and could be avoided. On slide 39, we should be looking for ways to reduce and eliminate exposure to hazardous chemicals, not only those that are typically talked about like alcohol and tobacco, but also known carcinogens, which are still out in the commerce and people encounter in the workplace. We should be replacing them with safer alternatives. We should be looking at the endocrine disruptors and getting away from exposure to them. Bisphenol A is a good example. You'll notice that the American Congress on Obstetrics and Gynecology already has a policy in place that recommends that pregnant women avoid exposure to bisphenol A and pesticides, and they have some other recommendations on their website that you might want to take a look at as well. It's gratifying to see them begin to take strong positions on ways we can begin to shape healthier pregnancies that will ultimately benefit offspring over the life course. We should be more regularly investigating occupational exposures that women might have in the workplace, finding out what chemicals they are, looking into their hazardous properties, and make certain we're doing what we can to reduce or eliminate exposures through replacement with safer alternatives or with personal protection. And on slide 40, this is just an indication of some of the sources of exposure to endocrine disruptors. I've given you a website here to the Environmental Working Group's database called Skin Deep. If you want to investigate some of the chemicals that are in cosmetic products that you might be interested in, you can go there and find out which ones have endocrine disrupting properties or which ones haven't been studied at all but are in these products. And then there are other personal care products like toothpaste and soap and others that may have endocrine disruptors in them. Parabens are frequently used. Preservatives, some of them have estrogenic properties. People are concerned about whether they might be related to breast cancer risk. We don't really know. The data are inconsistent and incomplete. They can be avoided and could be replaced. I also want to mention triclosan, widely used in toothpaste and some soaps. It's used as an antimicrobial agent. The FDA says there's no evidence that it's either safe or effective. Triclosan not only has thyroid disrupting properties, but it also, in laboratory studies, is shown to potentiate the activity of estrogen in certain models. So this is one that could be avoided. I've mentioned bisphenol A, which comes from the lining of cans, thermal receipts, and assorted plastics. There are ways to try to reduce or eliminate exposures. It's very hard for people who rely on canned food as a source of vegetables, for example, when they don't have ready access to fresh fruits and vegetables and other food products. I'm told that Campbell Soup Company has committed themselves to getting out of bisphenol A in the lining of their cans by 2020. We'll wait to see what it is they replace that with and whether it truly is a safer alternative. And then there are ways to avoid exposures to pesticides, whether it's food residues or home use or in farm workers. But we ought to be looking for those opportunities and promoting them. So finally, on slide 41, it's multidimensional strategies that we should be looking for. Healthcare providers have lots of opportunities in counseling to do environmental assessments of patients when they have the opportunity to really look at what patients are clients are being exposed to, and to look for ways to intervene to reduce those exposures. But there's something for governments as well, state, local, and federal governments, in terms of guidelines, regulations, labeling requirements, and research. Toxic Substances Control Act is a chemical policy, regulatory policy at the federal level. Right now, it's being hotly debated in the Congress, in both the Senate and the House. Many people who are probably on the call are involved in trying to influence that legislation. But we should be facilitating lactation, physical activity, food consumption, and chemical policies through various government mechanisms, not just hard-nosed regulation, but there are other ways to do it as well. Something in our communities and schools who really can weigh in that I've mentioned previously. And finally, increasing the research agenda to try to more urgently learn about some of the chemicals that we're being exposed to, about which we know very little. So thank you very much. That's a quick run through the ecology of breast cancer, and I'm happy to take any questions. Thank you, Diana.
Thank you, Ted. Can you hear me?
Yes.
Okay, great. Just something was making me think something may have gone wrong. So I'm glad. Thank you so much, Ted. You've given us a lot to consider, so I imagine we'll have some good discussion now. And now's the time when we'd like to invite questions and comments from our participants. If you would like to ask a question, simply press *2 to unmute your line and state your name and affiliation. We ask that you try to be brief so we can get to a few questions before we're out of time.
This is Dr. Roy Ozan, and question is on the types of diets that reduce breast cancer and all cancers. There's an ongoing confounding of industrial raised foods with traditionally raised foods. The Mediterranean diet is a traditional diet. There were many traditional diets that had near zero breast cancer. Many had red meat and milk in them, but none of them used industrially raised meat or milk. So I think that is a confounding factor that should be addressed. And then in the chemical side, I think it's time, just like the climate change people, we talk about getting petrochemicals out of our fossil fuels, but also out of our daily lives. Thank you so much for your approach, though. I think it's wonderful.
Thank you very much for your comments.
Hello, this is Fran Solomon from the Evergreen State College in Tacoma, Washington. Thank you very much for your very informative presentation. I was intrigued by the finding that a higher consumption of whole soy is linked with a lower risk of breast cancer, and I was wondering why that is the case. I had thought it was the other way around because of the presence of phytoestrogens in soy.
Yeah, thanks very much for the question. It's an important question and one that frequently comes up. I think the important point here is that whole soy is far more than a collection of phytoestrogens. There's no question that there are phytoestrogens in whole soy, and if we fractionate the soy, take out the phytoestrogens, things like genistein, for example, and then study them in the laboratory, you get a far different effect. There's no question that they promote that they're estrogenic, and you can cause a proliferation of estrogen-responsive cells. But whole soy is really a more complex matrix of chemicals in food. And studies that have been done comparing whole soy with soy fractions have shown, just for example, you ask about mechanisms, studies with whole soy have shown that you actually upregulate tumor suppressor genes with whole soy, whereas with fractionated soy, the soy supplement, the pure genistein, for example, you actually upregulate oncogenes or cancer genes. So I guess the point is that you get very different biologic responses when you study just the fractions of the soy versus the whole soy product, even at the level of gene expression. In studies in people, they're able to show, for example, that whole soy actually can modify hormone production and hormone metabolism. Studies in both rodents and in non-human primates have shown that lots of whole soy in the diets of prepubertal animals results in breast tissue after puberty and the development of the breast. It results in breast tissue that actually looks more differentiated, that there are fewer terminal end buds where the cancers are initially are initiated. So you actually get a very different looking kind of tissue after higher levels of whole soy exposure during infancy and childhood. This really is, for many people, counterintuitive, and this question comes up very, very often. So again, I would just emphasize, I'm talking about whole soy products here and not soy supplements or fractionated soy. And I would finally just repeat that what I said here actually has been confirmed by consensus statements of oncologists, something that I just learned a couple of days ago, that indeed groups of oncologists are in agreement that this is exactly what the studies show.
Okay. Thank you very much.
Welcome.
Thank you so much. Do we have another question or comment out there?
Good morning. This is Emily at Alaska Community Action on Toxics. And Dr. Schettler, I was just wondering if you might briefly mention the North Karelia project that you had mentioned to me, because I feel like it's pretty relevant to what we're talking about here.
Yeah, thanks, Emily. Briefly, the North Karelia project is one that grew out of the observation that in the 1970s, area in northeast Finland called North Karelia had the highest cardiovascular disease mortality in the world, and they were wondering what to do about it. And at about that time, some of the risk factors for cardiovascular disease were beginning to be identified by the Framingham study and others, things like hypertension and smoking and overweight and abnormal serum lipids and so on. And what they decided to do in North Karelia was, rather than identifying individuals at high risk and trying to intervene, they decided to actually attempt a population-wide strategy to dampen down these risk factors across the entire population. So they didn't give up on individuals, but they added to it by involving supermarkets and farmers and schools, city planners and others to initiate a population-wide set of strategies to dampen down these risk factors. And they did it quite successfully, and over a period of 10 years or so, they reduced cardiovascular mortality in North Karelia by 80%. And I've learned a lot from that study by simply because I think it's instructive about ways we might think about designing population-wide interventions to address some of these complex problems that have multifactorial origins. At the same time, clinicians continue to provide important care to high-risk individuals in their clinical practices. I think we could take some of the lessons from North Karelia and apply them here to think about how we might have population-wide attempts to reduce breast cancer incidence.
Thank you. I think we have time for one more question.
Yes, this is Mary Lou Ballwade from the Endometriosis Association. And because our women have a high risk of all of these problems, 12 cancers, heart disease, autoimmune diseases, we've been trying to focus on preconception planning and prevention, and finding it's a hard message to get across, perhaps because the OBGYNs tell these women, oh, you're going to have an infertility problem, get pregnant right now, or they go through IVF. Ted, you have such a long history in this field. Have you found ways to break through with that important message?
No, I haven't, Mary Lou, but thanks for bringing it up. I will confess that I haven't really attempted to do a look to see how to communicate this more convincingly. But I think what you're raising is an important point, that we need to think about preconception as well. I talked about beginning in the womb. It's clear that if we're going to have a healthy pregnancy, we have to think about preconception care as well. But I think that I have not figured out convincing ways to break through with this.
Thank you.
Thank you, and I do think we are just about out of time, so I want to take this opportunity to thank you again, Dr. Schettler, for your excellent presentation and the abundant resources that you provided for further exploring this approach to prevention. Remind everyone about the event in Nome tomorrow. There's also, Dr. Schettler was on line 1, your health connection, last week, and in the follow-up email that I send out, I'll send you a link to that radio program if you'd like to hear more. We'll also be notifying you when we've posted the MP3 recording of today's call to our website. Our next call will be about the health effects of coal development and lessons learned from the environmental justice movement in Central Appalachia. Our guest presenters are Shannon Elizabeth Bell, who's the author of Fighting King Coal, and our other guest is Carly Weir, Coal Campaign Director at Cook Inlet Keeper. The call will be on Wednesday, May 11th, and you'll be receiving an email announcement with a link to sign up within the next day or two. If you found today's presentation and discussion valuable, I hope you will consider making a donation in support of this great service. Your gift will provide the support we need to continue bringing you our monthly Che Alaska teleconferences. To make a contribution, go to www.akaction.org and click on the Donate Now button. Thank you so much. If you have additional questions or comments, please feel free to contact us. The phone number is 907-222-7714. or by email at diana@akaction.org. And thanks again to everyone. Have a wonderful day. Thank you.